Thanks again, everyone, for coming. Hopefully you've gathered a lot of information. I'm looking forward to the question and answer session at the end. So I'm going to talk about neuroendocrine tumors above the diaphragm. And so I have an interest in lung neuroendocrine tumors. So that's what we'll talk about. And they're different than the neuroendocrine tumors of the GI tract or pancreas. But they are very diverse. So we call these things pulmonary carcinoid tumors or neuroendocrine carcinomas. So depending on where they fall on that spectrum. There's some risk factors. We think about smoking, lung cancer, it happens in smokers. Well, not always. So sometimes the higher grade malignancies, the small cell lung cancer and the large cell neuroendocrine carcinoma, these are diseases of smokers. When we talk about the lower grade ones, there's not really a whole lot of risk factors. There are genetic syndromes, so I mentioned earlier MEN1 and MEN4. These can predispose to these, but a lot of times these, there's no risk factors. I see patients from, this disease really does not discriminate. My youngest patient was 11 when he was diagnosed, and I have very elderly patients and everyone in between. These are pretty uncommon. Okay, so the pulmonary carcinoid tumors are the lower grade neuroendocrine tumors of the lung. They represent about 2% of all lung cancers. So when you go to your general thoracic oncologist, this is really just a minority of what they see. But when you go to a NET specialist, this represents about 25% of all neuroendocrine tumors. So you're gonna, the NET specialists in the room, they see more and more of this, and I think people are starting to recognize that. Lung nets are increasing in incidence. So this is a graph of actually all neuroendocrine tumors by site. In general, neuroendocrine tumors are increasing, but the one that is increasing the most, this is lung right here. So we see, we're seeing more and more of this, and I think, some of it is it truly increasing, or are we just becoming more aware of things, and or do we have better imaging techniques, or are we just imaging more? You go into the ER for a stubbed toe, and next thing you know, you're walking out with a CT of the chest, and we sometimes find these things. So, okay. So some of the symptoms of the neuroendocrine tumors of the lung vary. So, a lot of it is respiratory. So recurrent pneumonia is, I see a lot of patients who have cough. They can sometimes cough up blood, trouble with the breathing, wheezing, chest pain. And again, a lot of these things are diagnosed incidentally. There are some hormonal syndromes that can come along with this, much less common than when we think about the carcinoid syndrome in patients with the small bowel tumors, or even some of the pancreas tumors, some of the hormonal syndromes that can come along with that. But we certainly can see this. So we'll check for certain hormone levels depending on the symptoms. So this is a CT scan of a patient, 45-year-old woman with an incidentally found lung nodule. So what we're looking at here is a cross-section through the body here. So this is the left side, right side. Here's the heart. The black things here are the lungs, and here's that tumor. So that is a very abnormal scan. So what do we do when we see that? That could be, we think about, all right, what are all these options that this could be? But it definitely needs to get worked up. And it all starts with a biopsy. And some of the things we talked about, Dr. Gupta talked about, some of the things we look for when we look at this underneath the microscope. So a differentiation status that tells us how does this look like? What does this look like compared to a normal lung tissue? The mitotic index, how many cells are dividing, in the Ki67 proliferative index. So this is again a marker we put on the this cell on the slide when we look at this underneath the microscope, and it gives us an idea, a percent of the dividing cell goes anywhere from less than 1% all the way to 100%. And the folks who are over at 100, 80, 90, 100%, very, very fast growing cancers. So there are some neuroendocrine specific labs, again, if depending on the symptoms, and then imaging, and then pre-surgical evaluation with pulmonary function testing. So tissue is the issue. That's there's an old saying in oncology: no meat, no treat. And so we really need to know what we're treating. So it all starts with the biopsy. We have you've heard over and over and over again today about our multidisciplinary approach to things, and so for the lungs it's a little bit different. We have so at Vandy we everybody's very siloed into what they do. So I go to two different tumor boards. I go to my neuroendocrine tumor board, and then I go to my thoracic tumor board, because usually the thoracic people don't. The surgeons, the chest surgeons, they're not at my neuroendocrine tumor board because they're operating on non-small cell lung cancers, so I go to these two different tumor boards, and thoracic is a little different. So we have our pulmonary folks and our thoracic surgeons and radiation oncology. So we all sit down and we look at pictures and come up with the best way to get a biopsy. But there's different ways to do a biopsy. Dr. Marcella, he showed you some pictures about some of the things that he does. But there's when you're in the lungs, you can do some of that. You can put a needle through the chest wall and do a biopsy like that, and he does that quite a bit. But a lot of times we'll do this through a bronchoscopy. So this is a procedure where we put you to sleep and actually take a tube with a probe, put it down into the windpipe, into the lungs, and we can actually use an ultrasound probe and actually visualize the tumor or lymph nodes on the other side of the wall and put a needle through there. Now I've got a picture of that. This is called endobronchial ultrasound. Thoracentesis, sometimes patients have some fluid in the lungs. We can take a needle and either drain that fluid out and get that biopsy. Pericardiocentesis is when there's a fluid buildup around the heart. Sometimes we send for open biopsies. So we send to our thoracic surgeon for an open biopsy. So this is just a cartoon of the chest, of the lungs, and some of the lymph nodes surrounding. So here's your left lung and your right lung, and all these little things right here. These are all lymph nodes. So how do we get those? Well, there's a procedure called a mediastinoscopy we sometimes use. We don't do this too much anymore, but we make a small little incision right at the base of the neck, and we can scope down there and we can pluck out some of these lymph nodes. As I mentioned, nowadays what we normally do is this EBUS probe or endobronchial ultrasound. So that's just a picture of what that looks like, and that little needle can go right through the wall of the airway and get tissue for us. So we talked a little bit about how these things, the grade 1, grade 2, grade 3 of the neuroendocrine tumors, the GI tract and pancreas, and they're all based on the mitotic index and Ki-67. And you can kind of see, how the reason it matters is because people with grade 1 neuroendocrine tumors generally do better than people with grade 2 or grade 3. In the lungs, it's a little bit different as far as classification. We break this into essentially 5 different categories nowadays. We say the slowest growing are what are called the typical carcinoids. So that's akin to the grade 1 neuroendocrine tumors, the GI tract or pancreas. Is based on mitotic index. So how many, when we look at the cells, how many are actively dividing, and also the presence or absence of necrosis. So notice we didn't even say anything about Ki-67. that comes more recently. So nowadays we're looking at the Ki-67 for this. And we call this carcinoid/NETs with elevated mitotic counts or Ki-67. So usually over 30%. And so this newest classification before we get to the large cell neuroendocrine carcinomas or the small cell lung cancers, which are the very fastest growing. So that's the pathology for lungs. But so now how do we image this? So we do our conventional imaging with CTs and MRIs, like Dr. Marcella had pointed out. We will always get an MRI of the brain if this is a small cell or a large cell neuroendocrine carcinoma. Those higher grade cancers, they like to spread, and they like to spread north. So it's always that's just part of the usual workup. If it's a lower grade tumor, we normally don't do that unless there's some symptoms that have developed. But we'll look at those dotatate PET CTs. There are two of them that we can order. The gallium-68 PET or the copper-64 dotatate PET. If it is a higher grade tumor, we'll get an FDG PET. So as you've heard over and over again, functional imaging, this detects the presence of somatostatin receptors. So on this side, this is actually what Marianne was talking about, the old Octria scan, and how it gave us these little fuzzy pictures. And if you squint and turned your head a certain way, you could say, oh yeah, there's a tumor right there. But here's the same patient with a dotatate PET, and you can kind of see how you see things so much better on the dotatate. So I was actually just talking to a colleague yesterday in Las Vegas. He called me up about a patient, and they don't have a dotatate PET capability where he's at. So he did an Octria scan, and it's just such an inferior test. So if someone recommends you have an Octria scan, just go somewhere else go somewhere else where you can get a dotatate. There are some differences, between the copper-64 and the gallium-68. We know they're both superior to the Octria scan. They're similar as far as concordance, as far as picking up lesions. But the big thing, and I think a lot of us have switched over to using copper alone, is because it has a much longer half-life. So it's actually made in St. Louis, and we order it, and it comes the next day, and we've got all day to use it. Whereas gallium, we need to make it locally and get it into the patient very quickly before it goes bad. So copper has really replaced gallium in what we do. But there are some pitfalls from the PET imaging. Most of the neuroendocrine tumors express these somatostatin receptors, but some of them don't. So sometimes you get a dotatate PET and it's completely negative. Sometimes not everything on a dotatate PET is positive. So you may have multiple liver tumors, and only half of them have dotatate receptors or somatostatin receptors. So there's some false positives. It really takes somebody who is who knows how to read this scan, because many times people will, especially when we first started this, we said, oh, wait a minute, there's uptake at the head of the pancreas. Do they have a pancreas tumor? Well, it turns out that's a physiologic or normal process on this. You can have uptake in the spleen. When I go through scans in the clinic with patients, I'll show the scan, and if we start up here and the first thing that lights up is the pituitary, and we have to say, all right, well, that's normal. Other things can light up, some post-radiation changes, reactive lymph nodes. We pick up a lot of meningiomas, actually, but we also, pick up things that we didn't expect to pick up. So there is some variability between copper and gallium, and so we sometimes really need to go back and say, all right, well, I've had patients that have had gallium at some point and then went on to get treatment, and then we get a copper afterwards, and the copper says, oh wait, it looks like there's different disease. And it wasn't necessarily progression, it just wasn't picked up on the gallium before. So, and we can't really rely on SUVs. So SUVs are the numbers on the, when you get your PET scan report, they'll say SUV max of 15, previously 12. You can't really rely on that to determine progression. You really need to look at sizes on things. So, and again, each patient really needs to be discussed individually in a multi-D setting. So this is the same diagnosis. So a big lung tumor here, PET positive, versus this one. So they're both typical carcinoid tumors, but we treat them very differently. You can see this one has a bone metastasis. So what do we think about when we start talking about treatment for lung nets? So again, this multi-D review, we got to look at stage. Is this an early stage? Can I potentially take this out and cure it, or has this already spread? What are the symptoms? Are there somatostatin receptors? So we always try to get a dotatate PET on patients prior to them going to surgery if we know about that. If we know about it. The bulk of disease, comorbidities, essentially lung function. So we get pulmonary function testing. Can they tolerate an operation? If I take out, unlike the liver, where you can, Dr. Boudreau showed you pictures of, a table full of tumors. If we had that table full of tumors in the lung, the patient's really going to be huffing and puffing when they get out of surgery. So we've got to. It's valuable real estate in the lungs, so we've got to be careful about who we operate on, and then obviously, looking at patient preference. So generally, for early stage pulmonary carcinoid tumors, we take them to surgery. Surgery is similar to how we would operate with a non-small cell lung cancer. Traditionally, we'll take an entire lobe. But we can sometimes get away with, especially with typical carcinoid tumors, less than a lobe, so we'll do something called a segmentectomy. We always look at lymph nodes and examine, we always try to take as many lymph nodes as we can to really stage patients. If a patient does not want surgery or they're not a candidate for surgery, we can do very high doses of focused radiation, something called stereotactic body radiotherapy, or SBRT, and that can essentially kill the tumor off. We do a lot of this in non-small cell lung cancer in those patients who have COPD and really bad pulmonary function testing. And as you can imagine, if we take out a lobe out of one of those patients, they're not going to do well because because they're not coming in with good breathing tests. So what we learned in that population is if we do this radiation, it's pretty much equivalent to doing surgery, except we don't get lymph nodes at that time. We're learning more and more about doing SBRT in the pulmonary carcinoid tumors, and it seems to be just as beneficial. Interestingly, in non-small cell lung cancer patients, if I take a tumor out and it has involvement of the lymph nodes, then we're generally recommending chemotherapy afterwards to try to kill off any other disease. In this disease, we do not give anything afterwards. The reason is we don't have any good evidence that it's beneficial. So we looked at all these different guidelines here. These are the NANETS, that's our parent organization, ENETS, which is the European Neuroendocrine Tumor Society, NCCN, which is a conglomeration of multiple cancer centers, including Vanderbilt, that come together and build guidelines for treatment of each cancer, and then ESMO, similar on the European side. And so at NANETS, I think it was in 2017, we all got together and said, patients with, the question was whether or not to give adjuvant treatment here. So we said adjuvant surgery without adjuvant treatment because there wasn't really much evidence. Everybody else said, oh, you got to give chemotherapy afterwards or radiation. So we went through and we actually published a paper and went through all of this, and we were able to get the guidelines changed for NCCN at least, and so now chemotherapy is no longer indicated in the U.S. for these patients. So these are the types of procedures you may see. This is, we look at things called a wedge resection, where it's simply that. You see I have a tumor sort of on the periphery up here, and we take a little piece of the pie and get rid of it. The more correct way to do this, something called a segmentectomy. So we take not an entire lobe, but a segment that the tumor is located in. We can do a lobectomy. A pneumonectomy is where we take the entire lung. We try not to do that because that compromises lung function. But if you have a tumor that's very, very proximal right off here, it's very tough to get away with one of the other procedures. There is a procedure called a sleeve where we can actually take out the part involved with the tumor, take out the part of the lung, and then put this part back together. So that's called a sleeve pneumonectomy. So in these, again, I'm not being a surgeon, I rely on the surgeons, and I'm sure they explain this a whole lot better than me. I mentioned SBRT, again, short doses of high dose radiation, usually given over a 5-day period. Pretty equivalent to surgery, but again, we do not have the lymph node data, so we don't again that sometimes prognosticates what how close we're gonna follow patients. Okay, so this is just a paper that looked at SBRT versus what we call fractionated radiation. So a lot of times fractionated radiation is given lower doses over a long period of time rather than high doses over a short period of time. So it turns out that, as Dr. Maluccio pointed out, anytime you have this separation of the curves, that shows a very significant benefit, and that's what we see here with SBRT. So this is a patient of mine. She's 75. She has an atypical carcinoid tumor. She was, you can see right here. She was not a candidate for surgery or decline surgery, so we gave her a week's worth of radiation, and so what you can see is that killed that tumor off. Interestingly, these things can sometimes occur within the airways. So sometimes patients will come in with trouble with their breathing or coughing up blood or wheezing, stridor, and we get a scan, and what we see here is right there. So that's the windpipe is in here, and this branches into the left lung and the right lung. So sitting right in the middle of that tube is a tumor. So what we can do for that is something called endobronchial therapy. So there's different ways to do this. We can freeze it, we can cook it, we can give it light therapy, but what it does is it kills that tumor off. And sometimes we can avoid an operation. So this is just a picture of a patient of mine that had this done. So you can see in the airway here, you see this tumor. They froze it. It's the cryotherapy, and that's what it looked like afterwards. They go back at 6 weeks, and so you see that airway is wide open. You may still have a little bit of tumor right here, so they froze it again, and then comes back at 8 months, and you can see it's completely gone. Oh, I had okay. So I have another slide that actually shows that same picture. I guess I didn't include it, this one. But essentially, we went back and did the same, looked at that same picture, but this thing was completely gone. And this was in he was 35 years old, and hopefully we'll not need anything else ever again, but we'll continue to follow. Okay, so what options do we have? Okay, so this is a 70-year-old patient of mine with typical lung carcinoid. Okay, so I mentioned slow-growing cancer, right? Typical. This is the slowest one, but you see how much disease this person has. So, well, sometimes we think about observation, and I'll talk more about that. We talked about some of the somatostatin analogs, radionuclide therapy, chemotherapy, immunotherapy, targeted therapy, liver-directed therapy. Do we do molecular testing? And obviously clinical trials. So, who can be observed? Okay, so sometimes we can observe people if they come in and we know that this is a typical carcinoid tumor. If they're asymptomatic, they have a low volume of disease, and then sometimes I say, all right, have you ever had a scan before? I'm sitting there looking at a scan. Oh yeah, I had a CT, 5 years ago for something, and we'll track down that CT. And if it looks exactly the same as the CT that's in front of me today, that's someone that maybe I don't need to rush them off to get therapy right now, because this is, again, long documented stability of disease. But usually when we decide to start somebody on treatment who has advanced disease, so people we're not going to operate on, we talk about the somatostatin analogs, and we have two that we choose from, either octreotide LAR or lanreotide. So these are the two trials that really showed that this can prolong progression-free survival. So you can see this is against a placebo, and you can see this is octreotide. The latest one was the lanreotide study. So again, this is placebo. This is lanreotide did much better. The problem is these things were not done in the lung neuroendocrine tumors, and it wasn't until this study where we really had prospective data to look at the lung neuroendocrine tumors. This was the SPINET study. It was actually just recently published. 216 patients they wanted, and they randomized patients to either lanreotide or placebo. Unfortunately, they did not. This was open for about 3 years or so, and they halted because of slow accrual. It was open worldwide, and we had this study open when I was in New Orleans, and I think we were the number one enrollers in the country with 3 people. It was a very hard study to accrue to. So they actually ended up with 77 patients before they stopped it. 58% were typical carcinoid tumors, and it turned out that there was a degree of benefit for lanreotide, but it was primarily seen in those patients with typical carcinoid tumors, not the atypicals. So that was actually just published this year. It was actually presented, the data, in 2021, and it just came out this year. So that's an option. The only FDA-approved therapy, FDA-indicated therapy for lung nets is actually everolimus. So this is what we call a targeted therapy. So this inhibits the mTOR pathway that the cancers use to grow. So this was actually based off of this RADIANT-4 study, which looked at patients with neuroendocrine tumors of the lung and also the GI tract, and randomized them to either everolimus or placebo. And it turns out that the everolimus did much better than placebo. So that led to the FDA indication for everolimus for lung nets. Doesn't mean that we don't have other options here. It just means that's when you look at the package, they say that's what this is indicated for. So the latest data comes from a study called CABINET. So this looked at a drug called cabozantinib, which is another oral agent. And they looked at two different patient populations. So they said pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors, so including lungs. So they randomized to either cabozantinib once a day versus placebo, and what they were looking for is, again, this progression-free survival. So how long does this work for? The important thing was to look at with this is you needed to have prior treatment for your tumor. So this was not a first line agent. So in lungs, everybody needed to have everolimus. You can see out of all the patients here, it was a minority of patients who had lung nets, but again, it was one of these things. Lung nets is an understudied entity. So I'm really glad they included this because this may give us another option here, because what you see here is the cabozantinib versus placebo. So did much better. This is the extrapancreatic cohort. So not yet. This has been submitted to the FDA. This is what came out in the New England Journal 2 weeks ago. So we'll see what the FDA says, but this could be another option for lung nets. Now, Dr. Maluccio talked about PRRT. Okay, so I won't belabor this. This was the NETTER-1 study where they looked at patients with mid-gut neuroendocrine tumors with Ki67s less than 20%, who were already on octreotide or lanreotide and then had growth on that. So they randomized them to either PRRT versus high-dose octreotide, and as we saw earlier, the PRRT was much more impressive. Response rates 18%. It doesn't mean that it's so when you read our papers and we say response rates, it doesn't mean that only 18% of people benefited from this. What that means is 18% of people had shrinkage of their tumors by 30% or more. So it's a very strict definition. So I often tell patients before they get on this, I say, all right, if I get a scan on you when you're done with your treatment and it looks exactly the same as the scan prior to the treatment, that's a good scan. It means this treatment worked, because you got to remember that disease was growing before you came in. So we've stopped it from growing. Obviously, we like to see it shrink, but that's not always the case. So if we have stability of disease, sometimes that's just as good. Again, this was in mid-gut nets. So we don't know how this works in lung nets. This is the NETTER-2 study. This is in the higher grade, first-line neuroendocrine tumors. Again, this is neuroendocrine tumors, the GI tract or pancreas. So we don't, there were no lung nets in here. So we don't really know. In a prospective fashion, there's a lot of retrospective literature that says, oh yes, PRRT works for lung nets. And so you can see that we have response rates over here that are in the 30 percentile, 20 percentile, and PFS or progression-free survival. So we use it, and if we look at all of our guidelines, our NANETS guidelines and NCCN guidelines, if patients have uptake on their dotatate PET CT, this is a tool that we use. How do we sequence therapy? We actually have this trial, which is open at Vanderbilt, which randomizes patients to either PRRT or everolimus. And so we're trying to figure out, all right, which one do we use first? Are they equivalent, or is one superior? People who will get onto everolimus, they take this until they progress, and if they progress, then they can switch over and get the PRRT. So this trial has been ongoing. It's a nationwide trial, so we'll have data in hopefully several years that'll give us an idea what to do. So does chemotherapy work in neuroendocrine tumors of the lung? Well, in some, I think. So when we think about some of the high-grade neuroendocrine neoplasms, small cell lung cancer, large cell neuroendocrine carcinoma, chemotherapy is the backbone. Okay, and we try to, this is looking at cisplatin and etoposide, and that's our general. That's what we generally do, and combine it with immunotherapy for these higher grade tumors. With the lower grade tumors, it's much different. So this is actually a lot of older studies because we really don't use this anymore. We've got other tools that we use. So this is IV chemotherapy, can certainly come with side effects. If someone comes in with a typical carcinoid tumor, I'm never using this on them. So what I will use is sometimes a combination of capecitabine and temozolomide, which is a regimen called CAPTEM. So we think about this in some of the pancreas tumors, which shows benefit, but in lung nets, it also seems to confer benefit. So this was a study that looked at only 33 patients. In the lung net studies, you won't see very large studies, but most of the patients were atypical carcinoid tumors, and it looked like they derived benefit, so a median PFS of 9 months with an overall response rate of 18%, so similar as to NETTER-1. So it has activity. It's something when I don't have tons and tons of things that in my toolbox, this is something I'll go to. This was another study that looked at lung nets from 2008 to 2018. This is 20 patients out of Moffitt, and they saw a 30% response rate and stability of disease in 55% of patients, so with an overall disease control rate of 85%. So I think it works. I think there's a study that's going to be opening that's actually an international study that's looking at patients, lung net patients who've been on CAPTEM, so we'll be participating in that, and maybe that'll give us a lot more information on the role of CAPTEM in lung nets. What about immunotherapy? The whole world is abuzz. There's about immunotherapy. So you see all the commercials on TV about Keytruda and Opdivo and other immunotherapies. Well, does it work in the neuroendocrine world? The short answer is there's not been very good studies that show immunotherapy does much in the neuroendocrine world outside of small cell lung cancer. But there is a little bit of data. The keynote studies, those are the Keytruda or pembrolizumab studies. Low response rates, 12% in carcinoids. There was another drug called spartalizumab. Again, this is low response rates in the whole neuroendocrine cohort, so 7.4%. But in the lungs, it was north of 16. So, all right, well, maybe there's something different about the lungs compared to the rest. So sometimes I'll use this. And what I'll normally use is this regimen, ipilimumab and nivolumab. And this was looked at a whole cohort, 29 patients with 11 of them being lungs. Overall response rate of 24%, but it was 33% in the lungs. So again, something a little bit different about the lungs. So this is not necessarily on the guidelines, but this is something that when I get down to, all right, you've gone through the everolimus, you've gone through the cabozantinib, you've gone through the PRRT, you've gone through your somatostatin receptors. This is something, if I don't have a clinical trial, this is something that we may end up using, and I've seen very dramatic responses actually with this. So it's, when we think about it, we don't necessarily, when we think about neuroendocrine tumors, we don't necessarily think about immunotherapy, but maybe we should. Essentially, more research is needed. This was actually an abstract we presented at NANETS a few years ago that actually looked at the number of abstracts in major meetings. We picked two major meetings. One was the North American Neuroendocrine Tumor Society annual meeting. The other one we picked was the World Conference on Lung Cancer. And we said, all right, well, how many clinical trial, how many abstracts pertained to neuroendocrine tumors of the lung, or not necessarily all neuroendocrine neoplasms, but the pulmonary carcinoid tumors. And it turns out that out of the total number of abstracts at NANETS, that's the number that had included pulmonary carcinoid tumors. In the World Conference on Lung Cancer, this went back to 2013, I believe. So several thousand abstracts. This is what we found out for this. And when we looked at primary clinical trials, 1% at NANETS, only so this was actually, well, this was 3% out of all trials in progress anyway. So in the majority of these things were actually single institution studies. This is our data we've done. I saw 100 lung nets at my institution, and this is what I found. So not too helpful as far as driving the field forward, but certainly more research needs to be done. And I always encourage companies to include the lung nets in their protocols. So I'll conclude by saying that the lung nets are uncommon in, as we've talked about, do need a multi-D approach to care. The treatment is based off of stage, grades, symptoms, and we always, have this discussion with patients and see what their wishes are. There are a number of treatments. We don't have 30 different drugs for this, but we do have a number of treatments, and again, they do remain poorly understood and should be included in NET protocols. So I'll stop there, and thanks for your attention.